Thank you and good afternoon. I would also like to start by thanking the Champalimaud Foundation, Madame Beleza, President Cardozo. I feel truly honored by the invitation to speak today. Now, my remarks will focus on the question of whether the world can bring an end to epidemics 100 years from now. And I see at least two issues to be considered under this broader frame. The first is, will the world end the current major epidemics that it is facing, namely HIV/AIDS, tuberculosis, malaria? And the other, will the world 100 years from now end the risk of emergence or re-emergence of epidemics? And let me join other fellow speakers in saying that as a scientist, and perhaps I would say also as a clinician and very much hands-on, it is difficult for me to speculate not based on experience or to some extent on the predictable. Anyway, to the first question of will the world end the current major epidemics, my answer is a cautious yes. Yes, because if I look at the progress that has been made in the fight against these epidemics, that progress has just been remarkable, with no precedent in the history of public health, and certainly a major source of hope for the future. The end of AIDS or the end of tuberculosis that were just unthinkable 15 years ago, not only have now entered the language of scientists, but have been endorsed as an objective that the world set to itself for 2030, as you may know, under the new frame of the Sustainable Development Goals adopted by the UN last September. And progress has been amazing, and progress has been amazingly fast. Let me just give you a few figures. The number of people accessing AIDS treatment has increased from 200,000 in 2000 to 16 million by now. The number of new HIV infections have decreased by 40%, and AIDS-related mortality has decreased by 35% just in the last 5 years. And the life expectancy of an HIV-infected person on effective AIDS treatment now is similar to that of an HIV-negative person. When it comes to TB, we've witnessed a 50% fall in mortality from tuberculosis in the last 25 years, with most of that improvement taking place since 2000. An effective diagnosis and treatment of TB is estimated to have saved something like 45 million lives between 2000 and 2014. And we've learned the ingredients of success. Ingredients of success, political commitment, and I'll come back to that. Resources, community mobilization, innovative approaches to delivering care, innovative approaches to international intellectual property framework pioneered by Brazil, to development assistance, and something that Dr. Orwitz alluded to the global governance of health. And importantly, of course, science. Science has been vital in advancing control and treatment of the diseases. New scientific evidence, products, approaches have rapidly been incorporated into programs. And interestingly, I think from a broader discussion perspective, the scientific community has been intimately involved in strategy development, in implementation, and in assessment of the response to the epidemics. I'm very confident that science will further generate efficacious new medicines, possibly leading to eradication of the virus from infected individuals, that is a cure of AIDS, and also most likely effective vaccines to prevent infection with HIV and to prevent transmission of TB. So if my yes is cautious, It's not because of the limitations I would foresee to progress in science. It is because ending AIDS and ending TB is not just about fully understanding transmissibility, pathogenicity, immune responses, and generating new medicines and vaccines. It's about our ability in the future to address the social, structural, and political determinants that underlie the emergence and the expansion of epidemics. Epidemics have always been powerful indicators of social and economic inequities, of structural weaknesses of health and social systems, and of failures to address the transnational nature of health. Thus, in contrast with the global progress that I mentioned earlier, only minor, very little progress has been made with the so-called concentrated epidemics of HIV or TB among vulnerable groups of the population. By vulnerability, if I think of HIV, I refer to young women in sub-Saharan Africa that have no control over their sexual life, men having sex with men, people who inject drugs, sex workers, incarcerated people in most parts of the world. HIV remains highly prevalent among these communities in both developed and developing countries. And access to prevention, information, and treatment remains disproportionately low. Thus, I believe that a strong emphasis, if not an over-reliance on biomedical approaches, has led to insufficient public health focus on fighting stigma, fighting discrimination, fighting inappropriate legal and policy environments, as well as an insufficient focus on social and political determinants of health. Just think of the major negative impact on the prevention of the transmission of HIV that the denial of the viral origin of AIDS by a former South African president had in a country that is still paying for this absurdity with one of the highest HIV seroprevalences in the world. And when it comes to people who inject drugs, I have the privilege, together with Fernando Enrique Cardoso and George Sampaio and other fellow members of the Global Commission on Drug Policy, to denounce the focus that countries have on repressive drug policies that emphasize prohibition and law enforcement rather than public health, approaches that have been fueling and continue to fuel HIV and hepatitis epidemics among people who use drugs. Another source of caution about the prospect of ending these epidemics is, of course, the challenge of resistance, now a major challenge for prevention and treatment of tuberculosis. Resistance may arise either from improper treatment regimens or TB programs that would fail to ensure that patients complete the whole course of treatment. Globally, multi-drug-resistant tuberculosis represents now 3.3% of new TB cases and 20% of previously treated patients who come from retreatment. But in some countries in Eastern Europe, these figures reach 30 and 70%. The recent Ebola outbreak, additionally, I think best illustrates how much health systems and access to basic health care are essential in the control of epidemics and cannot be compensated by other measures. In the absence of an effective treatment for the Ebola virus, recovery relies on simple measures like rehydration and access to basic care measures. And whereas the mortality from Ebola has been over 50% in the affected countries in West Africa, it is estimated that it would have been less than 10% under the conditions of functioning health systems in developed countries. And similar considerations, of course, would apply to cholera or dengue. At the time of the Ebola outbreak, please remember that Liberia had less than 50 doctors, 50, for a population of more than 4 million people. Clearly, international aid assistance has too long neglected structural factors and too long neglected investing in building sustainable health systems because of a sort of dominant technical vision of international health programs centered on medicines and vertical interventions that neglect social and structural contexts. And finally, answering the question of whether we will end AIDS and TB by 2030 or 2115 also involves asking whether the world will be able to reduce the social and economic inequities. And the question is legitimate, since, as discussed by other speakers already today, the gap between the rich and the poor is increasing. It's increasing across the world, it's increasing within countries, and particularly in the many countries that transition from a low income to a middle income status, and in the large emerging economies. But even with these qualifications, my answer remains a yes. I do foresee an end to AIDS and TB, at least as a global public health threat, and well before 100 years from now. If I could go back to what you said about cancer, I have no doubt that it will be cured, or that it will be curable. Whether it will be cured is another question. So whatever, but coming back to infectious diseases, whereas I'm saying I strongly believe that we can put an end to AIDS and TB and malaria as public health threats, I cannot, however, foresee complete elimination of these diseases. And elimination we define as zero incidence of new cases, or eradication, which we define as the disappearance of both the disease and the causal agent. Now to the second question of whether the next 100 years will see a world free of emerging or re-emerging epidemics, my answer at this time, despite my efforts to speculate on the future, must be no. Bacteria, viruses, parasites that may cause transmissible diseases coexist with humans and will continue to do so. Antonio Damasio spoke about the symbiotic part of it. I do not always look at microbes this way. And of course, the microbial world, we know, is capable of remarkable mutation, evolution, adaptation for its own survival. So, whereas eradication of infectious diseases has long been, and the idea of a world free of epidemics has long been an idealistic goal, I believe infectious diseases will never disappear. And that was first predicted by Charles Nicolle, the director of the Institut Pasteur in Tunis and Nobel laureate of medicine in 1928, in a book called Naissance, Vie et Mort des maladies infectieuses, Birth, Life and Death of Infectious Diseases. Moreover, of course, and as already discussed by some speakers today, global warming, the growth of transport and communications, the increase in the world population, the intensification of livestock farming, increasing contacts between humans and wild fauna, or the thoughtless use of antibiotics in both human and veterinary medicine, all point to the future emergence and re-emergence of epidemics. So eradication of smallpox in 1978 will, I believe, remain as the only example of eradication of an infectious disease. That was achieved through vaccination, but there are very specific reasons to that achievement. The humans are the only reservoir of that virus, and the disease is always symptomatic, so there are no silent carriers of the infection. In the other diseases for which we have effective vaccines, the goal is elimination rather than eradication. Diphtheria, tetanus, polio, whooping cough, and as you know, any loosening in vaccine coverage is immediately followed by re-emergence, as we have recently seen in several countries in Europe and in the US. So in the case of new epidemics and diseases for which no vaccine is yet available, the emerging strategic model for control of the epidemics I see will be, of course, a combination of several interventions that will all benefit from the technological progress that I fully share with previous speakers will be extraordinary in the years to come. Our ability, once we identify the disease, to identify the pathogenic agent, to build, design, and implement a test that will allow rapid testing at the bedside, mathematical modeling of the early stage of development of an epidemic to guide sensible public health measures, and treatment interventions that, even if imperfect, could decrease transmission and disrupt somehow the epidemic chain. But in addition, good governance, education, training of healthcare personnel and communities, economic growth that would reduce inequities, social and economic inequities, will all be essential in controlling infectious risks. So epidemics in the future, I believe, will persist, as predicted by Charles Nicolle, but epidemics will be better anticipated, detected, and controlled. And this will especially be true if we remember the lessons that we can learn from HIV and TB, that epidemics can be reversed when we address them not only with the tools of public health, but also with human rights and efforts to achieve social and economic justice. Thank you.